I'll go back now to the case, and we spoke about lenvatinib. And anything you don't like about lenvatinib? Side effects?
So that's a very good question. There's distinct side effect profile between sorafenib and the lenvatinib. If you look at the REFLECT trial, you will get more hand-foot syndrome PPE in the sorafenib arm, grade 3, versus lenvatinib is more of defined by generalized fatigue, weight loss, hypertension, proteinuria, sort of reflecting the more potent VEGF receptor inhibition. So clearly, it's not a walk in the park. We have to be aware of the toxicities and actively manage them. So there's some distinct features that you have to pay attention to with lenvatinib.
No, I totally agree. If anything, however, I think we all recognize and we are stressed ourselves by it, especially the hand-foot syndrome with the sorafenib can be really quite stressful, even though I give credit, some people really know how to master managing it per se. But nonetheless, no doubt that the lenvatinib profile is rather more appeasing in regard to management because at the end of the day, the hypertension is easily controlled, and at the same time, definitely a little bit of maneuvering in regard to the diet and appetite can help a little bit in regard to the symptoms. But also, last point, I was really very intrigued by the response rates that you brought up. And let me ask you from the perspective of the modified RECIST, let's teach our colleagues, what's modified RECIST?
So, modified RECIST really looks at what makes sense, which means the viable part of the tumor. So instead of measuring the entire tumor, which might be a 90% necrotic and show no change in size in the largest diameter, modified RECIST measures the largest diameter of the hypervascular part, or the part that is actually still viable. And that becomes biologically, I think, much more relevant in the treatment of hepatocellular carcinoma. And if you look at the correct way, I think, the modified RECIST way, then suddenly the response rate goes from mid 20-24% up to 40-41%. And that puts, I think, the activity of both agents much more into perspective.
Riyad, back to you one point. We proudly are able to talk to you guys now in IR, and if anything, us in oncology now we can talk about response. We didn't have response before.
We didn't.
We're very proud of that. But to be fair, what does it mean to you? Like, okay, now we tell you we have lenvatinib, response rate 41% by modified RECIST. How do you read what we do?
Yeah, look, Hassan, I mean, you're absolutely right. Historically, we've been the ones that in interventional radiology with local regional therapies have been the ones to sort of enjoy the higher response rates, no doubt about it. But now with some of the advents of the new therapies, clearly you're catching up, and the response rates are very impressive. Now, what does that mean? I think response to a patient makes a lot of sense. It's meaningful. It's certainly something patients want to hear. They want to know what the tumor looks like. Is it smaller? Is it dead, et cetera? Can we cut it out? But frankly, it also sort of extends the narrative to something that's very new, which is, again, historically, we used to talk about local regional therapies for downstaging, but now, theoretically, potentially, as we start to study this, can we start to think about downstaging with systemic agents? These are the facts. This is what I've sort of observed based on the literature. So again, I think we're going to have to be careful as to how we measure tumors, as you're mentioning with modified RECIST, and whether those are validated and whether those are accepted. But there's no doubt that now that narrative is now part of the systemic agent, something that has been sort of usually uniformly enjoyed by interventional radiology.
I like that very much. If anything, what we learned here is quite a bit. Number one is early diagnosis and screening are very critical, as Dr. Singhal mentioned. Number two is understandably, if there is a potential for a curative intent being surgery, RFA, or transplant, we're all for it. Sadly, as we learned from this case, and we see it with many cases, recurrence is a possibility. And if anything, there was a little bit of debate about the second RFA, but nonetheless, to cross that bridge, we have seen that ultimate patient recurred and now has systemic disease. We spoke a lot about the liver functionality and the importance of making sure that we kind of, keep patients or make sure we manage patients the best possible as a team in regard to the Child-Pugh-A good liver function, relatively speaking. And then ultimately, when we need systemic therapy, thankfully, nowadays, as Farshid mentioned, we have many choices, among which nowadays, sorafenib, lenvatinib, and we heard quite a bit about the lenvatinib, which, if anything, the new advent to it, being an anti-FGFR, it really has added certain perspective we have not seen before with sorafenib, among which, for example, response rates, which really, as we heard, 26% in regard to RECIST 1.1, up to 41% with modified RECIST. And more importantly is that ultimately patients are living an appropriate extension of life, as we have seen with the SHARP trial, seen with the Asia Pacific in regards to sorafenib, and now we're seeing with the REFLECT trial with lenvatinib.